Welcome to the regular meeting of the Public Health and Safety Committee for March 15th, 2023. I am Elliot Payne. I am the vice chair of this committee, and I am filling in for Chair Vita as she recovers her voice. At this time, I'll ask the clerks to call the roll so we can verify a quorum for this meeting.
Councilmember Wansley.
Present.
Rainville.
Present.
Ellison.
Here.
Palmisano.
Present.
Vice Chair Payne.
Present.
Chair Vita.
Present.
There are 5 members present, or 6 members present.
Let the record reflect we have a quorum. First, we have the consent agenda before us. There are 3 items on today's consent agenda. Item 1 is accepting a grant from the Mississippi Watershed Management Organization for erosion and sediment control enforcement. Item 2 is approving appointments to the Arts Commission, and I welcome both Lenny Moore and Jasper Lepak in the room for our Arts Commission appointments. Item 3 is setting a public hearing for March 29th, 2023 to consider an ordinance amending the noise violation exemption related to sounds associated with religious worship. Are there any discussions on this item? Councilmember Ellison.
Thank you, Vice Chair Payne. No issue, but just wanted to ask a quick question. The Arts Commission appointments, this doesn't seem like the right landing place, the right committee for the Arts Commission appointments. Just wanted to see if there was what the reason why they came to this committee. Seems like a biz function. It seems like just out of curiosity, I have no issue with the item.
Mr. Chair, Councilmember Ellison, Mary Altman, Public Arts Supervisor. The new Arts and Culture Department reports to this committee.
Okay. All right. I can follow up offline. I just wanted to. It just confused me. It feels like a biz function, but I just had some questions. So happy to take that up offline. Otherwise, want to welcome all the appointments and thank them for being here. So that's all.
And then before we call a vote on these items, I'd like to welcome up Director Brennan to introduce a new member of the city.
Thank you, Mr. Chair, members of the committee. I'm Andrea Brennan, Director of Community Planning and Economic Development. And I would like to introduce to all of you here Ben Johnson, who just started here on Monday. Do you want to stand up, Ben? Maybe step up here. Ben Johnson is the first ever Director of Arts and Cultural Affairs, a new department created by the City Council to really elevate arts in our community. So Mary Altman, who you just met, Manager of Public Art, Gugun Kayam, who is the Director of Arts and the Creative Economy, are reporting to Ben. And like I said, he just started on Monday. He comes from us from California. He was working for both the city of, most recently the city of Beverly Hills, before that the city of Los Angeles, doing arts and cultural programming and performing arts programming there. He has roots in Minneapolis and Minnesota. He's worked both for the Northrop as well as the Ordway. So if it pleases you, Mr. Chair, if Ben could say just a word or two, I could offer him that opportunity. Thank you.
Please, welcome.
Ben.
Thank you so much, Chair and Council. It's a great pleasure to be here. I don't have a lot to say, but I'm very much interested in digging in and making this great international world arts and culture city, as it always has been, and I want to really bring that back. So thank you so much, and if you have any questions, I'm happy to take them.
Any questions? Okay, not seeing any.
Great.
Councilmember Ellison.
No questions. Just wanted to offer a welcome. Thank you for this role, and you've got a lot of really brilliant people on your team here already. I'm sure that they're going to inform you and bring you up to speed. And it's great to know that you've got roots here as well. And I know that I've got the arts are sort of the center of my heart, especially. So thank you for the work that you're doing on behalf of the city, and welcome.
Thank you so much.
Thank you. Okay, seeing no further discussion, I am going to move to approve our consent agenda. All those in favor say aye. Aye. Any opposed say nay. That carries, and the consent agenda is approved. The next item is receiving and filing a presentation on staffing and operations at Hennepin County Emergency Medical Services. Here to present on this item are Martin Shearer and Dr. Nick Simpson from Hennepin EMS, and I'll welcome Chief Tyner up to make introductions.
Thank you, Chair Payne, members of the committee. It is my distinct pleasure to introduce from Hennepin County EMS my counterpart, Chief Martin Shearer and Dr. Nick Simpson.
Welcome.
Thank you, committee members. I'm Marty Shearer. Dr. Nick Simpson is with us. We're from Hennepin EMS. Just go over our agenda. We just wanted to give you a brief overview of Hennepin EMS, talk about the EMS responses in Minneapolis, talk a little bit about the day in the life of a paramedic, and just kind of a general overview of our system. I'm relatively new. I've been here about 3 years. Dr. Simpson, a little less than that. And I don't think we've done a good job communicating with the city councils of the areas that we provide service with. So we really want to just kind of communicate and have you ask questions and give us your foresight on ideas for the future as well. And so it just a kind of just a general discussion about what we do and how we do it, and we want to get your input as well. So as I said, Martin Shearer, been here since 2019, Dr. Simpson since 2020, and you can see we have a list of some of our command staff that are also relatively new. Some of them have been here many years, but most of them are pretty new. So we kind of trying to, we reorganize and have kind of a new culture and a new organization from what we've been in the past. So we'll talk a little bit just about Hennepin EMS. We're more than just the ambulance on the street. You know, we are that as well, but we also have community paramedics that really literally make house calls out with our community. They go to the people that really in the past maybe have called 911, but really don't need 911, but they need something else. So we go there. They do a lot of actually home care, administer medications. They do quite a bit of that. We also have our own dispatch team. We have our special operations team, which covers a lot of events like at the U.S. Bank Stadium, the Gopher Football Stadium, and like that. And then we do a lot of training, and Dr. Simpson is very involved in the training. And then we can let you talk a little bit, Dr. Simpson. By the way, Dr. Simpson, jump in.
Thank you. Thank you, committee. And so, yeah, so we'll just talk a little bit about kind of what EMS is and how we operate. And this really is, as Marty said, just an attempt to explain a little bit better about what EMS is, because I think some of you have done ride-alongs, which we greatly appreciate, as do the other responders and our partner agencies. But for those of you who haven't, I think it's often unclear what EMS is until you call 911. And so a number of things that we do as far as the sort of collaboration between operations and medical direction is everything is continually undergoing a process of improvement. That includes our protocols, that includes our equipment, our medications, education and training. And so we're constantly meeting with crews, talking about how we can improve the system, and this is an ongoing process.
And I will say Dr. Simpson has been really, really good about bringing new ideas to the system. And virtually every month he's been great, and we have a great working relationship, and they do a great job of training not only our team, but Minneapolis Fire, Minneapolis Police. And by the way, Chief Tyner's here. We have just a fabulous, fabulous relationship with Minneapolis Fire. For those of you who rode along, you saw that they jumped right on in the calls, and it's like they don't even have to talk to each other. Everyone just knows what to do, and we really want to thank you for your support of the fire department and what they do in the EMS world. So we have what's called a primary service area. So in this map, which is kind of hard to read, the colored areas are our service areas. So not only to cover Minneapolis, except for the far northwest section, which is covered by North Ambulance, we cover St. Anthony, Richfield, and we go all the way out to Lake Minnetonka. And so we have a fleet of about 38 vehicles, and we cover the area. And but most of our activity, about 80% of our activity, is in the city of Minneapolis. So we have most of our vehicles here, but we have quite a few out in the western suburbs as well, which is great because we can pull vehicles from the suburbs into Minneapolis when we need it, and we can pull vehicles from the Minneapolis in the suburbs when we need it. So it's a really quite an efficient system, and it works quite well. So call volumes and response times, this is a big number for Minneapolis, 75,000 calls roughly, and that's up 21, almost 22%. So our call volume has surged rather quickly, and we anticipated that surge after COVID, but we didn't anticipate this large of a surge. And so we've been trying to play catch up in our staffing model, but we were a little bit behind the ball on that too. And so there's a national shortage of paramedics. So we came up with a couple programs, which I'll describe a little bit later, about how we're trying to catch up with our staffing levels. But our average code 3 response time is just a little over 7 minutes. It used to be about 6:45, 6:30 in prior years. So it's creeped up just a little bit, and we want to start to creep it back down to where we think would be better. And then we have Code 2, which is Code 3 and Code 2 are a little bit of difference. Code 3 is the emergent, like heart attack kind of thing, lights and siren and everything. And Code 2 is a less emergent situation. For example, somebody's just got like foot pain or something like that. That's not really that serious. And then response times, once again, need to improve, which will improve. We have a surge of people coming on board, and we transport about half the people to the hospital. And we want to tell you that the behavioral response team that you have in Minneapolis is fabulous, and we'd like to see it expanded. They do a great job. We have a great working relationship with them, and it's working out really well. We weren't sure how it was going to turn out, but it's worked out really well. Dr. Simpson works with them quite a bit as well, and I don't know if you want to jump in there more, but I think they're really good.
Yeah, I've had the pleasure of being on scene with them a number of times, and I think they add a really nice perspective. They add a knowledge of a lot of resources that I think it's difficult for any one person to be able to provide, medical care and also keep track of all the various agencies and organizations and resources that are available. So I think they do a phenomenal job. They've added a lot to the response, and also in the times when you may not need a ambulance, police car, fire truck, it's a more subtle response, and I think that's something that we definitely heard the community ask for. So that's been a really nice addition. The other thing that Marty touched on briefly is that a lot of the responses to the scene are Code 3 emergency, and that's because we are still trying to improve the way that we better triage those calls. As those of you who've done rides, it's really difficult to truly understand what you're going to have when you get on scene until you get there. And so we're exploring additional evidence, literature, technology, ways that we can maybe do that better and decrease some of those lights and sirens calls that we may not need to do.
If you live downtown, you'd probably appreciate less sirens. So we talked about staffing. And so one of the things that we instituted, we did a pilot in 2020, and it turned out fabulous. So we started it again this fall, is our EMT to paramedic program. So we hire people that are EMTs. There's basically 3 levels of first responders. There's emergency responders, which is like a 40-hour course. There's an EMT level course. That's about a 180-hour course, and there's about 20,000 EMTs in the state of Minnesota. And then the third level is paramedic, which is much higher level training, about 2,000 some hours. And there's only about 3,400 paramedics in the United States, or in Minnesota, excuse me. And so the pool of EMTs is much larger to choose from. And so we're hiring EMTs. We hire them as a full-time employee, give them all the benefits, and then we put them through paramedic school for about a year. And then they go out and they join us as paramedics. And this way we would get a much more diverse population of team members. We get people a little more life experiences, and people that are generally care about customer care. And that's what we're really looking for. And so this program's worked out great, and we have a group of 18 that'll be coming on the street next month on this, so it really helps our staffing levels too. And then they commit to a 3-year commitment to us. And I should have paused before, actually, and let you ask any question about response time. Anybody have any questions about response times? That's sometimes the issue that people like talking about.
Councilmember Palmisano.
Yeah.
Thank you, Chair.
Yes.
Dr. Simpson, Mr. Chair, I had the pleasure of going on a ride along with you, sir, and I really appreciated understanding things from the EMT side. I also was able to go on a fire station ride along and got to see how our firefighters articulate with your staff. It's absolutely as you suggest. I am curious in this serious uptick in the number of calls that you are dispatched to in Minneapolis. What do you attribute that to? I don't think that's population growth. Is that coming out of COVID and people are out and about more, or do you know yet what that
Good question.
increase in call numbers attribute?
We don't have a full grasp of it. It's probably COVID related, but we also have just a large surge. It went from about 14% to about 22% of our calls that were mental health and substance abuse related. So those calls are up generally. Dr. Simpson, do you have thoughts on?
Yeah, I think it's certainly COVID related. I guess it's unclear exactly how it's played in, but we certainly see more traffic accidents than we used to because there's more cars on the road. We see people getting sick in other ways, and so I think it's probably all those things. People are out and about more. We're seeing interpersonal violence was up, and thankfully that is not as up as it was this time last year, but it's still an issue. And so I think there's a lot of factors at play. We see that nationwide. It's not just Minneapolis, it's everywhere. The larger communities certainly see a higher surge, but I think it is a question that we all would like to know the answer to.
Thank you.
And it's not just me, and so system-wide, we're up about 35% in call volume. So Minneapolis did not see as large of an increase as some of our other areas in our system. So yeah, it's a great question. It put a large strain on our team because, you know, we have to do 35% more work with this, virtually the same number of people, but we've been creeping up. We added a couple classes in November and December of 10, another class in February of 10. We have these 18 trainees coming on board. We're hiring another group of 20 trainees that start in 2 months, and we have another hiring class in April, I believe. So we're finally kind of catching up where we should be. And the hospitals approved us to add even more staff, so we'll move forward. So we really want to have not only meet the call volume, but also reduce the stress level on our staff as well. So,
Do you mind if I add one?
yeah, please go ahead. Yeah.
And so some of you guys may know this, but this trainee program has been a big step towards health equity, better patient care, and you know, historically, to do paramedic school, there's very few that are affiliated with a university or a college, and so financial aid is not available in that situation. So not having financial aid and also having to do a rigorous curriculum and potentially, you know, working on the side or establishing childcare has been very difficult, and I think it has historically further marginalized some communities more than others. And so I think this has been a nice step as people are hired on in a job and they are paid to do this, they're paid to go to school, and I think it really helps to decrease some of those barriers that we've seen, especially in some of our historically underserved communities to enter the field of paramedicine.
I'm going to call on Councilmember Wansley for a question.
Thank you, Chair, Vice Chair Payne. So I just had a couple of questions just following up from the prior one where you mentioned, of course, a huge volume of calls right now is coming from Minneapolis. Has that been a historic pattern, though, even prior to this year or even the pandemic where, you know, it was the bulk of your calls coming from Minneapolis, or just kind of the mixture of that?
Oh, yeah. I mean, historically, Minneapolis has always been the majority of our calls, just based on population density. I think that has shifted a little bit based on how everyone has surged. I don't know if you want to touch on that.
But traditionally we see a 3, 4, 5% increase in calls. You know, looking back through 2010 or so, that's pretty normal. In the past, before COVID hit, we were generally anticipating. You know, we'd look at the population projected growth and the call volumes, and Minneapolis was around the 3 to 4 to 5% range we would normally see. So this. You know, this is a big up, and then of course it dropped way down in COVID, and we're kind of like not looking at that year. We're looking at last year, which started to get to be back a normal year. Our record year for call volume was 2019, and we're right where we were, and above that now for Minneapolis, and so it's gone way up. And like I said, I'm not crystal clear. There's not like one silver bullet why it was created or increased, but it's up there. In a way, it's a good thing. In a way, it's a bad thing. But yeah, I mean, I think we're doing a good job of helping the community out there.
Yeah. No, absolutely. And I just getting a sense of, you mentioned kind of already that Minneapolis, because, you know, we are largely dense. It does make up a larger portion of your call volume, it seems like historically. You also notice, were there a shift in the responses or call, how did you code them? Like the code 2, code.
Yes.
You mentioned like opioid usage or mental health. Did you also see a shift in that from prior calls? Is that a relatively
that's gone up about threefold, actually, the code 2 calls. And a lot of that I can attribute to the shortage of paramedics in the scheduled transport world. So, you know, there's the 911 transports where people call 911 and the paramedics arrive, but there's also a number of ambulances out there that you call and say, hey, I've got a sick person at my nursing home that needs to go to a doctor appointment, and they schedule it to come at 3 o'clock, whatever. And that capacity is greatly diminished. And so a lot of people are using the 911 system when they used to use the scheduled transport system. And that's another part of the surge in calls. So we see a great increase in volume in the code 2 calls. And then we also see some agitation because sometimes it takes us, we prioritize those much lower, and sometimes it takes us an hour to get to these calls because we're going on the emergency calls, and we actually save a couple rigs that are available to go on emergency calls instead of the code 2 calls because we want to make sure when you're having a heart attack, whatever, that we can get there. And so that has prompted some agitation from some people saying, it took you an hour to get here. I called 911, it took you an hour to get here. But nobody's waiting an hour for a code 3 call, but they might wait an hour for a code 2, a non-emergent call.
Okay. And then,
Big difference on average response time. If you commingle those all together, it's a big difference. Yeah.
and then another question, like Council Vice President Palmisano, last year I had an opportunity to also do a ride along. And one of the things that came up as a challenge that actually this past budget session, my office worked with some EMS staff to try to reconcile on our new Office of Community Safety department is, you mentioned technology piece of this, and lessening the presence of sirens, in especially in particular communities where there's already an overwhelming presence. I think at that time there was conversations of what it would look like to pursue a new database. I think it's called I Am Sam or something like that, where I was really excited to see potential partnerships around that. From my understanding, you all have a new database, but some of the features that really excited me about that, especially when it comes to our unsheltered residents, it allows, communicative features where you can, over a phone, be able to assess someone, route prescriptions to a pharmacy, so you're not sending a rig. So just wanted to get a status update, or kind of like where the database was, and do you feel like it's been able to serve? It seems like that particular challenge, and also like, not just challenge, but from an equity standpoint too, of knowing, we don't want to be part of like the noise, the trauma that comes in certain communities when emergencies happen.
Absolutely. I could not agree more to all of that. In fact, one of the challenges that we've seen with various partners that we work with is that there are a lot of unknowns in this, because it is not something that we currently do. And so one of the things that we've been working really hard on, and I think we have got the pilot about to launch, and the last pieces are getting started hopefully today, so that we can trial this and see what that looks like. Yeah, the good Sam. And so with that would I think open the doors to a lot of possibilities, and it could potentially extend some of our mental health professionals, the BCR. I think it could potentially extend our physicians and PAs, and absolutely better triage calls that we do need to go to as well. And so I think that's going to open the doors to a lot of possibilities. And we are actively in the process of figuring out what that looks like. We just got, because of a number of logistical issues, the contract for that pilot just recently got signed. I think it was late last week. And so we're setting up the infrastructure piece this week. And with that, yes, I hope to really set the foundation to do great things at the city level, potentially county, state. And so I think there are a lot of opportunities there. I will talk about this for days if you let me. So if there's specific questions to that, I'm happy to go into that. Otherwise, I'm a huge advocate for that.
That is super exciting to hear. I'm so glad that there's like progress made on it. Definitely look forward to hearing updates of also how our staff in the Office of Community Safety, specifically our first responders, are also being able to interface with that new database in ways it's benefiting, some of the same components of lessening like the amount of sirens and better triaging some of the crises too, that takes off the strain of your workforce too. So super excited to hear that.
Yeah, so Good Sam, if you don't know, is a technology-based system that we can maybe triage calls or actually treat people over the phone like that. And to be honest, Good Sam would never have happened without Dr. Simpson. He ran into a lot of barriers and roadblocks, and his persistence and has driven this, and so now it's actually becoming reality. So it's a pretty cool thing. Yeah, so thanks, Dr. Simpson.
Thank you, Councilmember Wanzi. Councilmember Rainville.
Thank you, Chair. So, I have two questions, but first I have to thank you for the ride-along that we did on that warm August evening. It was a real eye-opener, how well you coordinate with our fire department and the police department. One of the calls we went on was a shooting, and your team interacted with the police so smoothly. The first question I have is, could one of you expound on, you talked about our BCR team and how helpful that was. Could you give a little more detail about that, please?
Yeah, absolutely. So as Marty mentioned, we have certainly seen an uptick in mental health calls and also substance-related calls. And I think it's no secret to, I think, anyone in healthcare that when you think about folks that are unhoused, when you think about people with financial insecurity, job insecurity, those things go hand in hand with substance use and mental health issues. And oftentimes those things are untreated. I think COVID added some barriers to getting treatment for a long time, which was not good for the mental health of the state, especially the city. And so with that, I think we've seen a number of things. We've seen calls where we have not had to go. And these are, typically lower acuity calls where someone is looking for resources, looking for help, but not in an acute crisis necessarily, and that's been quite helpful. We've also had calls that started out that way and then turned into an acute crisis, and the BCR has been great about integrating with other responders in the city and calling for sometimes that traditional response that is needed. And so I think that's really been the benefit, is being able to have conversations with their leadership and talk about ways that we can work together better, ways that we can integrate better, and really have a seamless kind of response collectively together instead of, we often in the past have had silos that sprung up just because it was different areas working on different things de novo, but this has been really nice with that collaboration.
Great.
Yep, I would say
Chief?
from an operational perspective, it's been really good. So, it was kind of an unknown. We didn't know how it was going to go. We had some rocky relationships with other communities and county mental health responders that didn't always go so well. And this team in Minneapolis is actually going well. So they're taking the calls that are appropriate for them to go on, and they're calling us when it's appropriate too. So it's just working out really, really well. So.
That's really great to hear. Thank you. And then when you talk about the increase in drug abuse, is that mostly fentanyl?
I think it's all substances. What we have seen over the last couple years is that whether someone was intending to use fentanyl or methamphetamine, typically they get both. And so we have folks that had no intention of using fentanyl that ended up using fentanyl and had an overdose, and that's certainly led to deaths and bad outcomes. We also have folks that thought they were using heroin and got fentanyl, and it's more potent. And so it is a very mixed bag as to what folks are getting when they utilize substances. And so I think that's been a challenge, is how can we, and that's some of the projects we have in the hopper right now, is how can we better serve folks, not only in that acute crisis, but how can we get folks tied into that next phase of care and hopefully decrease some of this recidivism of calls for substance use? How can we get folks into treatment and get folks on other kind of therapies?
And there's a drug, I saw a report on 60 Minutes called, I'm going to mispronounce the name, Xylocon, or it's an animal tranquilizer. It's ravaging
xylazine.
Philadelphia and Jersey.
Yes.
Have you seen that in our city yet?
We think so. The hard part is the xylazine is not a test that we typically, not something we typically test for in the hospital. And so that is someone that the Poison Center can occasionally send out samples, but it's not something that we do on every patient. And so if someone looks like an opiate overdose, was potentially using opiates, and then didn't wake up with traditional therapies with a naloxone that all of our responders have, that's the time then we think it's possible. We know we've seen some of it, we just don't know how much because it's hard to know.
Thank you very much. Oh, Chief, you want
Yeah, Councilman Rainbow, that's a great question. I think we talked a little bit during our ride-along, but there's really no pure drugs out there anymore. Everything that people buy for recreational purposes is really mixed with all kinds of things. And the same drug you take one time that worked well for you could kill you the next time. And there's no purity to anything anymore. And it's really challenging for us, because even when we respond, people say, oh yeah, this person took Fetty or whatever, fentanyl, but it turns out they weren't taking fentanyl, it was something else, and so it's and they don't even know what they're taking, and it's really challenging for the community and the first responders and our emergency department staff to try to figure out what's going on out there. But we do get alerts. The sheriff's department keeps us advised well when they see a surge in certain medications coming around, so we keep an eye out for that. But that's a challenge for sure. Yeah.
Thank you, and I look forward to our next ride-along.
Yeah, that'd be fun. And so I don't want to take a whole bunch of your time, but we have some other programs that we have too. Once again, we're trying to increase diversity. We started a talent garden last year. This is young people from generally from Minneapolis area, and that have an interest in healthcare in the future. And we brought them into the hospital, and they were able to kind of be like a mini internship during the summer. We did teach them all to become EMRs, emergency responders. So they took that 40-hour course, and they got certified in that. And then a lot of them, they interned in dermatology, they interned in EMS, they interned in hyperbaric. So it was actually a really, really fun group of young individuals that came along with us. And we hope in the future that they'll be interested more in healthcare in the future. So that was just another opportunity for us to see more people and bring them along our team. So just quick on the day in life of a paramedic. This is some of our team members. I just pulled a typical day last year, late last year. We go on about 250 calls a day. That's about a call every 6 minutes. We transported 146 people, about 61 to HHS. We average about 44 people. 44% of our transports go to Hennepin EMS, so we transport to everywhere, hospitals, Methodist, Southdale, Abbott, everywhere. Dispatch received about 1,000 calls. We responded to trench rescue, a person jumping off a bridge, a structure fire. That particular day, there's no shootings or stabbings, which is kind of unusual now for us. We had several overdose and cardiac arrest calls and baby not breathing calls. So this is a typical day for us. You just never know what you're going to run into here. Here's our team members. I'll let Dr. Simpson talk about a new project. We started off as a pilot last year, and it worked so well, we're incorporating that now into our standard operating procedure. But go ahead, Dr. Simpson.
Absolutely. And so this image is from one of our specialized teams. Just to tag on just a little bit to that opioid discussion is in the harm reduction front, one of our specialized groups, the community outreach group, has been very active in partnering with the Rumler Foundation. And so now we have naloxone leave-behind kits on every ambulance. So if there's a call where someone's in a home or we see bystander naloxone used a lot, we're able to refill those bystanders and friends and family with naloxone before we leave, so they have that, which has been nice. This image is from our specialized teams we call the P3s, and they were the first group to have ultrasound. So these folks, one of the first things we do for many of our patients in the emergency department at Hennepin is we use an ultrasound to get some quick diagnostic information on what's happening inside. This was an image from one of our crews. There was a patient that had a car accident, and he seemingly looked okay, but then when they used the ultrasound, they saw that he was actually bleeding internally, and quickly made the decision that, okay, we can't wait, for this lower acuity person to go. We're going to have to take this person now. And right before he got to the hospital, his blood pressure dropped. He almost arrested, but didn't, and they were able to get him blood, get him to the operating room, and he did okay. But since seeing the benefits of this ultrasound and the utility, we've now, very soon, in the next few weeks, we'll be adding it to every ambulance and training up all the paramedics on this.
Thank you. And like I said, ultrasound is one of our new improvements. We're always looking to improve. We have, thanks to Dr. Simpson and his medical direction team, all kinds of new medication. We're ordering new cardiac monitors. They just arrived like 2 weeks ago, and we're putting those into service too, and they'll have CO detection on it. We mentioned the Good Sam pre-hospital integration. We've got a lot of other different protocols we're working on and continuous technology upgrades. We also bring this technology to our first responder partners like Minneapolis Fire and Police and try to incorporate them all. And once again, it's an improved service and also send the right resources to the right call is really ultimately what it looks at. I'll let Dr. Simpson talk about the medical direction team. They do a great job. Our education team teaches about 10,000 student hours a month, so that's a lot of student hours out there.
So we are very fortunate to have 6 medical directors, and that currently includes our fellow who is doing his last year of EMS training. He'll be hired on in July, and then we'll have 6 full-time medical directors and then 1 fellow the next year. But we have a variety of different interests and strengths, and so from the community outreach front, some of you guys have talked with Dr. Tim Coomer. I know he does a lot of discussion with Minneapolis City and how we can better partner and serve each other that way. We have, I won't go into everybody, but I know that some of you guys have had conversations with Dr. Coomer, but yeah, it's a great group. I think we have a diversity of thought. We have a lot of different approaches, and so it's been helpful to have that. You want to talk about the advisory work group?
Sure. 2 years ago, we started the EMS advisory work group. So we got community leaders to join the group along with some EMS people and police and fire people. And the direction of that group is kind of lead us into the future and what do they want to see from us. And we talked a lot about where we're going, what we should do, and this group has been fabulous. So it's really nice to see and get a lot of community input, and that's another reason why we're here is just input from all of you in the future where we go. Because in the past we've always just been like there and responding and never really talked to you much about it. And even though we're not a city department, we want you to treat us like the city department, just like your police and fire departments. We work for you. So please let us know. You might get a monthly newsletter called EMS Dispatch, Hennepin EMS Dispatch. It might go into your spam folders. Hopefully you get a chance to take a look at it. Every month we try to update people on what we're doing, once again, just to improve communications. And we have a lot to be proud for. We have a really good organization, and we talk about some of the things we do. And you'll see some of the dramatic saves we have in there and some of the issues we have with, too. We try not to sugarcoat it all and talk about the truth about what's going on. And glad to say our surveys have come back great. We are ranked number 2 now in the nation, and our survey scores of 98.9% of our patients really are satisfied with the service they got. We'd actually do better if you'll see the next slide. We have our top 5 and our top lowest scores. And the comfort of the ride of our ambulance is always our lowest score. And I'm not sure if it's potholes or the winter or what, but we always get a terrible score in the comfort of our ride. So if we can improve the ride of our ambulances, we would get a much better score. But other than that, we do really, really well. And one of the things I really like to see is the extent the paramedics treat the people and the respect they give them. Those are some of always our highest scores. So we get this monthly, and it's a really good report. So we track it quite well. Thanks. And then our paramedics are out there also trying to help the community. We had John Sylvester, he's in the top photo there. He did the sock drive for homeless, and we have all kinds of events that we're trying to do quite often to help the community out. So our medics really care about the communities they serve in. And then we are just trying to wrap it up, and we'll take any questions or recommendations for us.
Councilmember Vita.
Thank you, Chair Payne. My voice is gone, Marty. I was preparing for you to come, but see what happened. Yeah. Thank you both for being here. You too, Dr. Simpson. My office has learned so much about what paramedics do from the two of you and the partnership that you have with so many different departments within Minneapolis. So I welcome more teachings from the both of you on how we can help and how we can better collaborate. One of the things you said, Marty, was that you don't reach the most northern part of the city, which is my ward. And you told me that right away. So I spent my time on the ride along with you in Councilmember Ellison's ward, but then I later did a ride along with North Hennepin, yes, so that I could see what was happening in my ward. And so I think a lot of people don't even understand that there's a line to where you all go and how calls and all those things come in. So that's why I was grateful that you were coming here to present and show exactly what you're doing and where you're doing it. And to keep up the good work, our first call, Marty, was a baby not breathing in George Floyd Square. And we were so worried about if we were gonna be able to get in or not. And Minneapolis Fire just stepped in, made sure the area was good and safe and that people understood that there was a baby who needed care right away. But we were definitely worried about what we were gonna be faced with when we got there. And so you all are talking to each other and you're understanding the best ways to serve our city. And I'm grateful for that. I like I said to you, every time I see you, tell me what I can do to help. Tell us what we can do to help as a council, and we're happy to do so. And thank you both for this work. And thank you, Chief Tyner. Thank you so much for coordinating this. You and the Office of Community Safety for coordinating this and putting this together to bring it before the committee. Thank you.
Thank you, Councilman Vital. Yes, I would say that we have just an incredibly outstanding relationship with the police and fire departments in the city of Minneapolis and the other teams as well. So thank you, Chief Tyner. They go on about 60% of our calls in Minneapolis, which is a lot of calls. Never complain. They always are doing the right thing, and it's just a tremendous relationship we have with them.
I can't forget to say thank you to John Sylvester, because he not only lives in my ward, but he also reaches out to my office quite a bit to talk about ways that we can get more people of color involved in these careers. He has a wealth of knowledge about homelessness and resources in downtown Minneapolis in particular. I think he was leading that initiative, the Downtown 100, for some time and working really hard to move forward with that, with figuring out who are regular people that are in downtown and what services they need and how we can better serve them as a city. So big ups to John. He's also very wonderful.
Yes, John, I think it was last year, won the Minneapolis St.
Yes.
Paul Healthcare Worker of the Year Award. So
The Hero Award of
Hero
the
Award,
Year.
that's right,
And
yeah.
he also rescued my dogs before.
Okay, yeah.
Yes.
Good news. But once again, we're here to let you know that we work for you, and we want direction from you if you need it. We gladly come back. I don't know what frequency you want us to come back, once a year, once a month, once every 6 years, whatever you want, we'll make it happen. And we appreciate the great working relationship we have with you. And any comments you have, you can contact us anytime. Dr. Simpson.
Before we wrap up, I just had a quick question on our dispatch and triage process, and I was just curious if you could expand, because you're covering a lot of different jurisdictions, and so you're having to coordinate with a bunch of different departments, and I was just curious if you have pretty standard protocols of when an ambulance goes out in a fire rig, or when a police officer has to clear before the ambulance shows up. Is that all pretty like standard protocol, or is it pretty dynamic that's determined once you get on site?
It is very standardized. And so the way this works is the initial call from the city will go to the primary public safety answering point, which is, I believe, in the basement here. And that initial call taker will determine what sort of category this falls into from a list of different options. And so if this is a short of breath call, someone's having trouble breathing, then typically you'll get fire and EMS. If it's an overdose call, you get police, fire, and EMS. And as some of you have seen, I think it's really important to know that the reason that's standardized is because on every scene, depending on the situation, in a car accident, the police are there to ensure that traffic is appropriately rerouted, to make sure that the scene is safe and evaluate for any sort of criminal issue. Fire is there to help extricate patients and provide any sort of fire suppression that's needed, and then we're there to provide the medical care. And so each scene has very distinct roles into what each agency frequently does, and so I think that helps from a standardization standpoint, which is why we can show up to a car accident, an overdose, and everybody kind of knows what's expected of them. So it is very standardized. In fact, from that primary safety answering point, primary public safety answering point, the next place that goes is if EMS is needed, it'll go to our dispatchers, and that's when we hopefully can get a chance to connect with the caller, ask additional questions, and further clarify what kind of response is needed. So it is a intricate, complicated process, but very, very standardized.
And then I was curious, for that standardization, especially as we're bringing on new capabilities like BCR, is there a pretty regular check-in on whether or not those protocols need to be updated, or should it be an ambulance paired with BCR, or I'm just curious how that kind of evolves over time.
Yeah, so when the BCR first started, as that team was building up, there were a lot of discussions with Director Hodney about how that was going to work and which calls are best for BCR. And so there was a lot of discussion at the Minneapolis dispatch level about that. And my understanding is the BCR is all under Minneapolis Police Department. So it is not a fourth service, but it is sort of embedded within MPD, and I'm sure there's logistical reasons for that. So yeah, it is very standardized as to what calls they can go to, and the dispatchers all have very clear lists of this is appropriate, this is not appropriate, and so we just want to make sure we get the right resource to the right person at the right time, and so yeah, lots of collaboration as that team was building up.
Well, that's just really great to hear, and I'm really excited about this. So I really appreciate you coming down for this presentation. I think the majority of us are new, so I think just getting this type of deeper knowledge is so beneficial for us. And Councilmember Ellison has a question.
I was just going to pile on the praise and just thank you guys for not only the presentation, but I also got a chance to do a ride-along, and just the professionalism, the coordination, getting able to see you guys do your work is really incredible. So, and I think this is the first time I'm sure you guys have been before the council before, but it's my first time. Oh, you haven't, so I was gonna say, it's my first time. The first time I remember seeing you guys come before the council, and it's really welcome, and it's great to see you guys and to see the leadership there. And Chief, you've got this whole Lee Marvin thing going on, and like it really exudes a lot of confidence. And
I say Leslie Nielsen.
Okay. so I really appreciate that, and thank you for the presentation. That's all.
Yeah, thank you. Actually, Dr. Simpson deserves more credit than I do. Like you just mentioned protocols. He's aggressively, we're about to launch next month our electronic versions on an app, the protocols, and it covers the fire department, it covers everybody, and we can change it on the fly, right? In the past, it's in these written books, and you had to wait 2 years before you could change a protocol and all that stuff, and now we can do it just, boom, make it happen. So, and Dr. Simpson comes up with these great ideas, and so I just stand back and say yes. So.
Well, it sounds like I'm the only one on the dais that hasn't been on a ride-along yet, so I think you should expect an email from my office pretty soon.
Thank you, everyone. I appreciate your time. Sorry we went over what we thought we were going to take, and thank you, Doctor, how about Chief Tyner, for coming as well. He is kind of a doctor, though. Any other questions for us? Okay, thank you so much for your time.
All right. Well, I will direct the clerk to receive and file this report, and thank you all so much for coming. And seeing no further business before us, and without objection, I will declare this meeting adjourned.